A very warm welcome to all you listeners tuning in to this episode of the Irish Haematology Oncology Podcast. I'm your host, Eoin Tabb, and I'm thrilled to have you join us today for a deep dive into a topic that's absolutely crucial in the field of oncology and haematology, safe prescribing in systemic anti-cancer treatments, or SACT for short. Not one to miss up an opportunity. I recently did a presentation for the Royal College of Physicians of Ireland for those doctors who are undergoing their SPR roles. And in it, I did a talk on the safe prescribing of systemic anti-cancer treatments. So I said, why not convert this into a podcast? So for just like those who are starting off their careers in the SPR world or in the world of oncology, the medications we use are incredibly powerful and the stakes are undeniably high. That's exactly why we're here today, to break down the complexities, share some practical tips, and hopefully make you feel a bit more confident in your prescribing practices and also in your reading and reviewing practices of those prescribing. So whether you're a doctor who's writing the prescription or whether you're a nurse or pharmacist or other healthcare professional who's reviewing those prescriptions, all of the tips in this episode will be applicable to you. So grab a cup of coffee, settle into your favorite chair or as you're driving your car, and let's get started. Now, you might be wondering, why all the fuss about SACT prescribing? Well, the truth is, these medications aren't your average pills or potions. They're classified as high risk for a reason. Think of them as a tightrope walker. There's a very fine line between therapeutic benefit and potential harm. One small misstep, one tiny error in dosage or administration, and consequences can be severe. And it's not just that narrow therapeutic index that makes SACT prescribing so challenging. These medications often come with complex dosing regimens that can make your head spin. Think of the last episode we did there on chemotherapy sequencing. Plus, our patients already battling the physical and emotional toll of cancer are particularly vulnerable to any adverse effects. So, as the oncology registrars or haematology registrars, the responsibility that rests on your shoulders in prescribing is immense. So don't worry, we're going to equip you with the knowledge and tools you need to navigate this high-stakes world with confidence. Right, let's talk about the first cycle of systemic anti-cancer treatments. This is where it all begins, where you lay the foundation for safe and effective treatment. It's like building a house. You need a solid blueprint, a clear plan before you even start laying the bricks. And that blueprint is the treatment plan. It's not just a piece of paper. It's a roadmap that guides every step of the patient's journey. It includes everything from their demographics and diagnosis to the specific chemotherapy regimen, dosing schedule, and supportive care measures. But creating a treatment plan isn't just about filling in the blanks. It's about having a meaningful conversation with the patient, ensuring they understand the treatment, its potential benefits and risks, and that they are given their informed consent to proceed with treatment. Once the treatment plan is in place, it's time to roll up their sleeves and get down to the nitty-gritty. This involves a thorough review of the patient's medical history, checking their biochemistry, calculating dosages, and considering any potential drug interactions. And let's not forget about supportive care. This is where you anticipate and address any potential side effects or complications, ensuring the patient's comfort and well-being throughout their treatment. All of these items need to be included in the treatment plan. Look at the NCCP Medication Safety Report from 2014. It highlights the minimum criteria or the minimum amount of information that needs to be included in a treatment plan to safely proceed. And it's all well and good recording that in the patient's notes, but these need to be accessible across all disciplines because the pharmacist who's reviewing it needs to know the rationale behind this treatment plan, and the nurse who's administering the drugs as well also needs to look at that treatment plan to make sure that they book scans, ensure that they're getting the correct bloods and biochemistry for this patient, and if there's any acknowledgements of dose reductions or things like that, that all needs to be recorded there, and it needs to be recorded so that it's accessible from all of those disciplines. So think about where you can record that. Do you have an electronic prescribing system like NSYS? Or do you have an email thread or something like that where you can record it that it's accessible from everyone? So now that you have that first cycle prescribing complete, the journey doesn't end there. It's like a long road trip. You need to keep checking the map, reassessing the route, and making adjustments as needed. In subsequent cycles, it's crucial to reassess the patient's fitness for treatment. This isn't just about physical strength, it's also about their biochemical parameters. Are their blood counts within the acceptable limits of the protocol? How are their liver and kidneys functioning? Based on this reassessment, you may need to adjust the dosage or even delay the cycle. Look back at our episodes on renal and hepatic impairment and on anemias, thrombocytopenias, neutropenias as well. So it's like fine-tuning that musical instrument. You need to make sure it's perfectly in tune before you start playing again. Is that patient well enough to go ahead? And speaking of fine-tuning, let's talk about dose calculations. It's not enough to calculate the dose once and assume it's correct for every cycle. You need to verify those calculations each and every time, ensuring there's no room for error. Has the patient gained or lost weight? Is there a need for a dose reduction of that patient according to the protocol? Remember, each cycle is an opportunity to reassess, adapt, and adjust, ensuring the patient receives the most effective and safest treatment possible for that patient at that time on that cycle. Okay, now let's shift gears a bit and talk about the legal side of SACT prescribing. It's not the most exciting topic, I know, but it's incredibly important. Think of it as the fine print in a contract. It might seem boring, but it can have serious implications if you don't pay attention. In Ireland, there are specific legal requirements and prescribing standards that we need to adhere to. These aren't just arbitrary rules, they're designed to protect both patients and the prescribers. For starters, prescriptions must be legible. It might seem obvious, but you'd be surprised how many errors occur simply because someone's handwriting is illegible. So take your time, write clearly, and avoid ambiguity. If you can use electronic systems, it gets rid of that handwriting illegibility as a means of error. But some of our prescriptions at the moment need to be handwritten. So look at your high-tech prescriptions. They come on a high-tech prescription pad. For oncology drugs at the moment, there is a move to move them onto the high-tech hub in the near future. That will reduce that error, but just look at your handwriting for the time being. Next, every prescription needs to be dated. This creates a clear timeline of the patient's treatment, which can be crucial in case of any questions or disputes down the line. Of course, the prescription also needs to include the patient's full name and address. This ensures the medication is dispensed to the right person and helps prevent any mix-ups. And finally, the prescriber's signature and medical council MCI number, the medical council registration number, are essential. This confirms the prescription's authenticity and holds the prescriber accountable for decisions. So remember, the legal responsibility for the prescription ultimately lies with the person who writes it. So take this responsibility seriously. Follow the standards and ensure your prescribing practices are above reproach. Okay, let's go into the specifics of SACT prescribing. So it's like writing a complex computer code. Every character, every symbol needs to be precise and unambiguous. Ambiguity is the enemy here. You want to leave no room for doubt or confusion. So when you're writing a prescription, be specific, be explicit, and leave nothing to chance. Remember, you are dealing with a myriad of healthcare professionals, each with different levels of experiences, some brand new to the world of oncology and haematology, or sometimes even just brand new to the world of hospital care. So think about those healthcare professionals who are reading the prescription. Leave nothing to doubt. So how do you avoid that ambiguity, right? Use approved medication names. Stick to the official approved names of the medications you're using. Avoid using abbreviations or clinical trial names. So one that's often brought up is CPT-11, which is the clinical trial code for irinotecan. Avoid using that. Nicknames, another one, RSC, cytarabine. Use cytarabine. Don't use the nickname of RSC. Or brand names, unless absolutely necessary. So for brand names, you can use brand names and are encouraged to use brand names when talking with biosimilar medication. So things like rituximab, use rituximab, and then in brackets use Mabtira or Truxima. Then we talk about dosing precision. So use dosing precision. Pay close attention how you write those doses. For doses that are less than 1 milligram, always include a leading zero. Example, 0.5 milligrams instead of 0.5 milligrams. That 0.5 milligrams, if you use that point could be missed and it could look like 5 milligrams at 10 times dose. Similarly, for doses greater than 1 milligram, skip the trailing zero. So use, for example, 1 milligram instead of 1.0 milligrams. Again, that dot could be missed and that 1.0 milligrams could look like 10 milligrams. Again, a 10-time increase in that dose. Details can prevent those massive mistakes happening. Dose clarity, always specify whether the dose you're writing is per day or the total dose. This is especially important for medications administered multiple times daily or over several days. You could actually write both if you wanted to make sure it was super clear. So this drug will be 1,000 milligrams per day for 4 days, 4,000 milligrams total dose. And the route of administration, be explicit about how the medication should be taken. Is it intravenous, IV, oral, subcutaneous, or something else? If it's an infusion, include specific details like the type of solution, volume, and infusion rate. By following these guidelines, you can significantly reduce the risk of errors and ensure patients receive the right medication in the right way. Remember, clarity is your best friend when it comes to SACT prescribing. And you may be asking me here at this stage of the podcast, why are you talking about all this? We have systems in place. Some places have pre-printed prescription templates. We have e-prescribing systems that you just prescribe Folfox and everything else is done. Well, there has been cases whereby computer systems have gone down and you need to go back to pen and paper. And you also need to have a critical eye over and not to trust these e-prescribing systems. There can be errors with a click of a button where you select the wrong regimen by accident. And instead of just automatically going, yeah, that looks good, look down through it. Is that right? Maybe you selected an IV bortezomib instead of a subcut bortezomib containing regimen. That's an error right there. So make sure you have a look through it and ensure that you have prescribed, because if the system is prescribing for you, you're the one who's signing off on that. Now, you might think that once you've written the prescription, your job is done. But in the world of systemic anti-cancer treatments, there's another crucial step: pharmacist verification. Think of the pharmacist as your trusty sidekick, your second pair of eyes, ensuring everything is in order before the medication reaches the patient. Pharmacists aren't just rubber stamping your prescriptions. They're independently verifying every detail, double checking your calculations, and ensuring everything adheres to the established protocols. They are also reviewing the patient's baseline tests and organ function, making sure they're fit for treatment and that the chosen medication is appropriate. And if there are any concerns or discrepancies, they'll flag them up, acting as a safety net to prevent any potential errors from slipping through the cracks. So don't underestimate the importance of pharmacist verification. It's an essential part of the safe prescribing process, adding an extra layer of scrutiny and ensuring the highest level of patient safety. So now let's talk about a specific category of anti-cancer medications that often fly under the radar, and that's oral anti-cancer medicines, or OAMs for short. These might seem harmless compared to their intravenous counterparts, but they come with their own set of unique safety challenges. Think of OAMs as a wolf in sheep's clothing. They're convenient for patients, allowing them to take their medication at home, but that taking at home can also be prone to errors and mishaps. You don't have the oversight and the viewing of them. So one of the main issues is the disconnect between prescribing and dispensing. OAMs in Ireland are often prescribed in hospitals, but dispensed in the community, leading to potential communication gaps and misunderstandings. It's like ordering a pizza online, but having it delivered to a different address. You might get the wrong pizza, or worse, no pizza at all. To ensure the safe use of OAMs, it's crucial to subject them to the same rigorous safety processes as parenteral chemotherapy. This includes clear communication between hospitals and community pharmacists, robust verification procedures, and dedicated OAM clinics to monitor patient adherence and address any concerns. Remember, OAMs might be convenient, but they're not without their risks. By implementing robust safety measures, we can ensure these medications are used effectively and safely, minimizing the potential for harm to our patients. I might do a podcast on that OAM model of care document from 2020 in the future. It's a helpful guide as to how we can minimize those risks for OAM prescribing and dispensing to our patients. Now I'm just going to go into some specific personalized prescribing items here now. So the first one I'm going to look at is the role of DPYD testing. So it's not a one-size-fits-all scenario tailoring treatment to an individual. DPYD testing is a prime example of this. DPYD is an enzyme responsible for breaking down certain chemotherapy drugs like fluoropyrimidines, so 5-FU, capecitabine, and Tegopur containing drugs. Variations in the DPYD gene can impact how quickly or slowly a patient metabolizes these drugs. So why does this matter? So patients with reduced DPYD activity are at a higher risk of severe, even life-threatening side effects from standard doses of fluoropyrimidines. We test for DPYD, and this helps identify these patients with genetic variations beforehand, allowing for dose adjustments or alternative treatments if recommended. The genotypes and phenotypes that are tested will guide you as to the dose recommendations for that patient. So sometimes if it's a severe genetic variation, it will call for you to start the patient at 50% dose and then escalate to 75% dose for the second cycle and maybe an 85% dose for the third cycle onwards. There are different variations in those dose adjustments, so just follow the guidance that has been issued by your testing laboratory, or if you have a DPYD protocol in place. DPYD testing, it's a proactive step towards safer, more personalized prescribing, reducing the risk of serious complications. Now, let's look at another safety challenge as well for your prescribing practices, and that's medications with similar names. It's like navigating a field of identical twins. So think of trastuzumab emtansine, and trastuzumab deruxtecan. They're all very easy to mix up, but they have vastly different side effect profiles and indications for treatment. So what are the strategies that you can employ? So one of the strategies is tall man lettering. So when writing or speaking these drug names, emphasize the differences using tall man lettering. So you could have trastuzumab on its own, you could tall letter the Z and the U. For trastuzumab emtansine, you could tall letter the emtan part of the word. They also recommend that you use these in tandem with the brand name. So as I said earlier on, for the biosimilars, again, this is an occurrence where the brand name is recommended to be written alongside it. So for trastuzumab, you have your biosimilars here in place as well for trastuzumab. So for trastuzumab, you write trastuzumab and Herceptin in brackets, or trastuzumab Herzuma or trastuzumab Ogivri in the brackets beside it. For trastuzumab emtansine, you write Kadcyla, the brand name, in brackets beside it. So include your internationally recognized name, and you also include your brand name. For trastuzumab deruxtecan, include Enhertu in brackets beside it. So for these, don't rush when prescribing, dispensing, or administering. Take a moment to verify the exact drug and formulation. If available, electronic prescribing systems flag that potential sound-alike, look-alike issues. And for the manufacturing of these drugs, and if you have a barcode scanner in place, if you have trastuzumab deruxtecan, if you have Enhertu prescribed by the doctor, and you go to barcode scan a vial of Herceptin or one of the other trastuzumab brands, it will not allow you. It'll come up as an error. So leverage those electronic prescribing systems. And again, communication is key. Open communication between prescribers, pharmacists, and nurses is vital. And it's recommended that in all communication, so in your diary entry, in your email correspondence, when you're talking to one another and confirming treatments, that you use both that international recognized name and the brand name. So remember to include both of those names for those sound-alike, look-alike antibody drug conjugates. And now, for the last second, let's finally talk about anthracycline. So these are powerful drugs like doxorubicin, daunorubicin, and epirubicin, and idarubicin. Bleomycin comes into it as well for maximum cumulative dosing. The maximum lifetime cumulative dose for these drugs is put in place to minimize the risk of heart damage. These guys can cause free radical damage and target those myocytes, those cardiomyocytes, and can cause severe cardiac damage. So, how do you manage this one? So, calculate carefully. Keep a running total of each patient's cumulative anthracycline dose. Include doses received elsewhere in other hospitals. So that might mean having to contact those hospitals and get the full medication history or the complete regimen details for that patient, and calculate out that patient's cumulative anthracycline dose. Factor in other risks. So factor in considerations like age, pre-existing heart conditions, and concurrent radiation therapy when assessing a patient's risk. In that case, you might have to lower down that lifetime. If a lifetime limit is approaching, explore alternative treatment options, or can you remove that anthracycline agent or that bleomycin from the treatment to ensure that the patient isn't tipping over to that cardiotoxic over that lifetime limit. And also, if concerns arise, involve cardio-oncology specialists for further evaluation and guidance. So that brings us to the end of today's episode on safe prescribing and systemic anti-cancer treatments. We've covered a lot of ground today, from the high-stakes nature of SACT prescribing to the specific guidance and strategies to ensure patient safety. Remember, safe prescribing is a collective responsibility. It's about clear communication and meticulous attention to detail, and a relentless focus on patient well-being. As always, I want to thank you, our wonderful listeners, for tuning in and being part of this important conversation. Your dedication to providing the best possible care to patients is truly inspiring. If you have any questions, comments, or feedback, please don't hesitate to reach out. You can find me on the social media or through the email link below. I'd love to hear from you. I'll put those links in the show notes below. And as always, I'm going to end on this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. Thanks a million, guys.